Hello, everyone, and welcome to our module on the healthy patient. Healthy patients commonly present to their providers for what is often called a routine evaluation. In these circumstances, they don't have a complaint that they want addressed, but instead they're seeking evaluation for screening and prevention of disease. Basically, they want their provider to review their health and see if there's anything that they should be doing differently so they don't get sick in the future. And in general, in medicine, if we're going to screen for a disease, that disease has to meet a couple of criteria. The first is that it has to have a high burden of suffering. We generally don't screen for minor diseases. We screen for more serious diseases like heart disease and cancer. Secondly, you have to have good screening tests. That should be obvious, but that's a criteria. And then finally, and this often comes up in board exams, we only screen for diseases where there are effective early interventions. If we have no treatment for a disease, then screening for it and identifying it early is only going to cause people to worry because there's no treatment. On the other hand, if we have a treatment that is effective when it's used early, that's the perfect disease to screen for because our intervention can have a big impact. So in this video, I'll go through the major conditions that we screen for in adult medicine, and let's start with cardiovascular disease. So cardiovascular disease usually means heart attack and heart failure, but it can also mean strokes and peripheral vascular disease, and it's one of the most common conditions seen in adult medicine. And in cardiovascular disease, there are several major modifiable risk factors, and the word modifiable is important. So a family history of heart disease raises your risk of heart disease, but that's not modifiable. You can't change your family history. On the other hand, all of these items on the slide here are risk factors for cardiovascular disease, and they can be modified if you change your habits or you get treatment. So these are the things that patients are screened for, where we often recommend an intervention or counseling if we identify one of them. So first of all, diet. We screen for patients to make sure they're eating a healthy diet. We screen for obesity, physical inactivity, and smoking. And that's because all these things are associated with cardiovascular disease and they can all be modified. I've put them in blue here because these are sometimes called the lifestyle risk factors for heart disease. And that's because they're a function of the lifestyle you choose to lead. In terms of medical conditions, the three main players in terms of risk of cardiovascular disease are hypertension, hyperlipidemia, and diabetes. And that's why we always screen for these conditions at a general medical visit. Most patients will have their blood pressure measured, and they'll be referred to the lab to have their lipids measured and to have their glucose or hemoglobin A1C measured as well. If you think about who's at risk for heart disease, the biggest risk group are those that already have heart disease, for example, patients with coronary artery disease. Once you have heart disease, you're at higher risk of developing more heart disease down the road. There are, however, a couple of groups of patients who do not yet have heart disease, but they're at the same risk as people who already have heart disease. And those groups include people with chronic kidney disease. Chronic kidney disease is a very strong risk factor for cardiovascular disease, and patients with diabetes. So identifying diabetes early is very important because treatment is associated with lower risk of heart disease, and anyone with diabetes has a risk of developing a heart attack or heart failure that is the same as someone who already has established heart disease. Let's talk a little bit about obesity. So we usually describe obesity in terms of the body mass index. The body mass index is the weight divided by the height squared. A normal BMI is less than 25. A person is considered overweight if their BMI is between 25 and 29, and anyone that is 30 or greater is considered obese. The main way we treat obesity in the United States is through behavior modification. This is what's indicated for most patients. It's the mainstay of treatment. You encourage patients to make long-term changes in their eating behavior and activity. It doesn't always work as well as we'd like, but you should be aware in a board question if they describe a patient who is moderately overweight or mildly obese, the first thing you want to try is behavior modification. There are some drugs that can be prescribed, but they're rarely effective and not generally used. One of them is orlistat, which is on the market. It inhibits pancreatic lipase to try and cause fats to be less absorbed. Bariatric surgery has become very popular as a treatment for obesity. The idea here is to surgically modify the stomach so that it can't hold much food. Therefore, patients get full very quickly, and if they eat too much, they actually can get sick. This is a very effective treatment, although it's invasive and carries significant risks, but studies have shown it often leads to significant sustained weight loss, and it's even been shown to reduce or limit complications of obesity like the development of diabetes. It's generally indicated only for people with a body mass index greater than 40, so these people are severely obese. Sometimes it's done in people with a BMI from 35 to 40 if they have comorbidities already, like diabetes or hypertension. Here's a slide I include to help you identify incorrect answers on your board exams. All of the items listed on the slide have no definite benefit or an unclear benefit for prevention of cardiovascular disease. So giving aspirin for primary prevention, in other words, giving to someone who hasn't had heart disease yet, has never been shown clearly to be of any benefit. Believe it or not, doing a routine EKG is not beneficial. EKGs are only helpful in patients with symptoms. Just doing one every year on somebody has never been shown to improve outcomes. C-reactive protein, measuring the thickness in the wall of the carotid artery, or measuring calcification by coronary CT scan, all of these things have been shown to be associated with cardiovascular disease, but they've never been shown to have benefit in terms of screening asymptomatic patients. And then finally, you may know from some of the other videos, especially the ones I have in biochemistry, that high levels of homocysteine or lipoprotein A are associated with cardiovascular disease, but measuring these in a healthy patient has never been shown to do any good. So all the items on this slide may be listed as an answer for a healthy patient when you're asked what should you do next. Usually these are going to be the wrong answer because they've never been shown to be beneficial. Moving on, let's talk about cancer. There's a lot of cancer in the United States, and there are a number of things that general practitioners do to try and prevent the development of cancer. Now, when most people think about preventing cancer, they often think of a mammogram or a blood test. But in fact, the American Cancer Association recommends all these general measures shown on this slide in order to prevent cancer, and none of them involve blood tests or diagnostic imaging. So first of all, being physically active, maintaining a healthy weight, and eating a healthy diet are all associated with a lower risk of cancer. And we'll talk a little bit more about that on the next slide, but patients who are sedentary and overweight are more likely to develop cancer. If you avoid smoking, as you may know, there are a number of cancers associated with smoking, so if you don't smoke, your risk is lower. Alcohol consumption is associated with cancers, especially liver cancer, so limiting alcohol consumption prevents cancer. STIs, sexually transmitted infections, are associated with many cancers, so you want to avoid those. And obviously, avoiding excess sun prevents melanoma. So all these things are often the right answer in a board question that describes a healthy patient and says, what should you do to prevent cancer? Don't necessarily jump to the answer that says a mammogram or a blood test for a prostate antigen. One of these things shown in the slide may actually be the correct answer. So when we talk about screening for obesity, many people think we are screening for risk for cardiovascular disease, and that's true. But we are also screening for risk for cancer. Excess weight is associated with risk for many cancers, and in fact, obesity is estimated to cause 20% of all cancers. If you have an absence of excess body fat, you have a lower cancer risk for all of these cancers shown on the screen here. Some of them, the mechanism is obvious. For example, the endometrium is stimulated by estrogen, and people that are obese tend to have more estrogen. But even for all these other cancers shown here, patients who are obese tend to have more cancer. And therefore, when you recommend a healthy lifestyle, you're not only giving that patient advice to prevent cardiovascular disease, you're also giving them advice to lower the risk of cancer. Now let's talk about screening for cancer. There are three major cancers we screen for in healthy adults. Those are breast cancer with a mammogram, cervical cancer in women through a pap smear, and colorectal cancer through a colonoscopy or sigmoidoscopy. At the step 1 level, they're not going to ask you at what age you start screening. You don't need to know all that. You just need to know the test that is used. But another important thing to remember is that a mammogram does not prevent breast cancer. It just identifies it at an early stage. Same is true of a colonoscopy. It doesn't prevent colon cancer. It just identifies it at an early stage. So if you're asked a question about prevention versus screening, make sure you're clear on whether the answer you're choosing prevents that disease from starting in the first place, or whether it just screens for the disease and identifies it at an earlier stage. There are a number of infectious diseases that we immunize for among healthy adults. First of all adults should get influenza vaccine every year. The pneumococcal vaccine is recommended for adults under 64 years of age if they are high risk, and high risk means they have pulmonary or cardiac disease, and over 64 years of age if they are not high risk. All adults should be immunized for varicella zoster. Sexually active patients should be immunized for HPV. Adults require a booster for tetanus, diphtheria, and pertussis. These immunizations are often administered to children, but adults often need another booster as they get older. The meningococcus vaccine is recommended especially for people college age living in dormitories. And finally, there is a vaccine for hepatitis B as well. There are a number of sexually transmitted infections that we screen healthy adults for if they are at risk, meaning if they are sexually active. First of all, chlamydia and gonorrhea infections are often asymptomatic, and you can screen for these with a vaginal swab or a urine sample. There is something called a nucleic acid amplification test, or an NAAT, and this test detects organism-specific DNA or RNA. We screen for hepatitis B. We also screen for hepatitis C. Hepatitis C can be sexually transmitted. although it's more often transmitted from dirty needles. In particular, people who were born between 1945 and 1965 are at particularly high risk for hepatitis C. It's interesting, the virus wasn't described and characterized at that point in time, and many people who have hepatitis C were born in that period. They were probably exposed from blood transfusions or in hospitals or during surgical procedures. And then finally, among sexually active patients at risk for STIs, we screen for HIV and also syphilis using either the RPR or the VDRL screening tests. There are a couple of things we screen healthy adults for that fall under the heading of psychosocial screening. First of all, depression is very common, so we always screen for that. There are a couple of substance use disorders we screen for: alcohol, tobacco, and other drugs. And then finally, and this is a topic that often comes up in your exams, we should be screening healthy adults for what's known as intimate partner violence. Intimate partner violence is violence against an individual by their spouse or boyfriend or girlfriend, and it's suggested when on physical exam there are multiple recurrent injuries or accidents. On your board exams, they're always going to ask you what you should do next if you suspect intimate partner violence. And you should know that your primary concern needs to be the victim. You should be supportive. You never want to say things that might make the patient feel bad if they don't speak up. You don't want to threaten them by saying, if you don't say something, more people may get hurt. This is often a difficult topic for discussion. And so what you really want to do, and this is almost always the answer on board questions, is you want to ask the patient if they feel safe at home. That's a screening question. And then if they say they don't feel safe at home, you want to make sure they have a safe place in emergency. This is key. Many patients are not quite ready to report their partner, but you want to make sure you work with them to identify a place that they can go if they don't feel safe, because people that get hurt are often people that don't have anywhere to go. And there are some states that have mandatory reporting requirements, but not all of them do, so you probably won't be asked about this on your exam. We screen for osteoporosis in all women over 65 years of age. That's because it's very common, and there are many treatments available, from calcium and vitamin D all the way up to bisphosphonates. Younger women and men with risk factors are screened. There are some men who are in families where osteoporosis is common among males. And the screening test is called the DEXA scan. It's the dual energy X-ray absorptometry scan. And I talk about this in more detail in the videos on bone in the musculoskeletal section. And I'll finish with this slide. So we do screen for abdominal aortic aneurysms in one group of people. Male smokers age 65 to 75 should have a one-time ultrasound. And that's because this is the group that has the highest rate of abdominal aortic aneurysms. And if you identify them early, as you may know, there is surgical intervention. So this is something a lot of people forget about. It sometimes comes up in a discussion of a healthy patient, what screening should be done. If they are in this age range and they smoke, what the question is probably looking for is to see if you're aware that that patient should have a one-time abdominal ultrasound to screen for an aneurysm. And that concludes our video on the healthy patient.